Hello everybody. Today we have meeting with one of the best bariatric surgeon in the world. Welcome, Doctor.
Welcome to you and to all watchers.
Doctor, today we will discuss the complications of laparoscopic sleeve gastrectomy. Doctor, laparoscopic sleeve gastrectomy (SG) is a restrictive procedure initially developed as part of the staged approach for high-risk super-obese patients. SG is increasingly being performed as a standalone operation with good weight loss and resolution of obesity-related comorbidities. A study of 14,776 sleeve gastrectomies confirmed that SG was intended as the sole operation in 86.3% of the procedures. Sleeve gastrectomy involves creating a sleeve of the stomach over a bougie and removes a large portion of the greater curvature of the stomach, leaving a small tube along the lesser curvature. SG also produces a decrease in ghrelin levels for up to a year, which may reduce the desire for food.
Significant advantages of SG include low complication 3 to 24% and mortality 0.39% rates, the ease of performing the procedure, preservation of the pylorus, maintenance of physiological food passage and the avoidance of foreign material.
Doctor, what about bleeding as a complication of laparoscopic sleeve gastrectomy?
Bleeding can occur from the gastric or short gastric vessels during dissection of the greater curve. Most of the bleeding problems associated with SG occur from the staple line after transection of the stomach. The bleeding is most likely a result of the large staples used for the thick tissue in the distal stomach. Large staples are not adequate to seal small vessels. This has led many surgeons to reinforce the staple line by oversewing, buttressing, or both.
Doctor, what about stenosis as a complication of sleeve gastrectomy?
Narrowing or stenosis can create gastric outlet obstruction. The presentation varies depending on the severity of the obstruction and can include dysphagia, vomiting, dehydration, and the inability to tolerate an oral diet. The gastroesophageal junction and the incisura angularis are the two most common areas where stenosis occurs, and this can be diagnosed by an upper gastrointestinal series. The most common reasons for the development of narrowing or stenosis are oversewing the staple line and using a bougie that is too small. The preferable bougie size is currently debated in the literature and can range from 30 to 60 French. In most cases, surgeons use the 36 to 40 French bougie for the sleeve construction, and the larger sizes of bougies are reserved for when SG is being performed as part of a staged procedure. Management of stenosis primarily consists of endoscopic dilation. If the area of stenosis is too long, surgical intervention may be necessary with conversion to a gastric bypass surgery, gastric stricturaplasty, or resection with gastrostomy.
Doctor, what about gastric leak as a complication of sleeve gastrectomy?
Gastric leaks after SG are one of the most serious complications and can occur in up to 5.3% of patients. Most leaks are due to local factors at the site of the staple line, such as inadequate blood supply and oxygenation, which impede the healing process. Leaks can also be due to gastric wall heat ischemia, a consequence of the heat generated by the cautery used during dissection of the greater curve. Although the blood supply to the stomach is robust, the gastroesophageal junction tends to be an area of decreased vascularity and thus more prone to leaks. Additionally, the stomach tends to be thinner at the angle of his, and some authors suggest that the large staple height used by many surgeons may not adequately seal this area of the stomach. Some surgeons recommend leaving a small portion of stomach distal to the angle of his and then imbricating with the running silk suture. However, Clinical studies have not provided evidence that reinforcing the suture line decreases the rate of leak after sleeve gastrectomy. Sleeve gastrectomy produces high intragastric pressure, which can affect the healing process and lengthen the amount of time for a leak to close. Reoperation with primary repair during the early postoperative course is the best option for a leak following SG. Clinically stable patients may be able to undergo percutaneous drainage, antibiotic therapy, and parenteral nutrition until the leak is healed. Endoscopic therapy with the use of stents has also been employed for management of leaks, but migration of the stents has been a problem. Early diagnosis, adequate drainage and gastric decompression are the mainstay of treatment for leaks.
Doctor, what about reflux after sleeve gastrectomy?
Gastroesophageal reflux after SG presents with classic symptoms such as burning pain, heartburn, and regurgitation. It can occur as an early and late complication. The first-line treatment is anti-reflux medical therapy. Reflux unresponsive to anti-reflux medical therapy with no clear anatomic abnormalities, such as stenosis or a hiatal hernia, can be effectively treated by conversion to Rozong-Y gastric bypass.
Thanks, doctor, for these excellent information. We will continue to talk about bariatric surgery complications in my next videos. Thanks for watching our videos. Do not forget to like and share. With my best wishes. Dr. Atif Ahmed.